A lot of these diseases that I treat are very poorly understood and often mismanaged and often misdiagnosed. My name is Gena Foster, and I am an assistant professor of medicine at the Yale School of Medicine. I'm a classical hematologist, and my area of expertise is in autoimmune blood disorders. We have a patient who is very young and who has poorly controlled HIV. He has AIDS, essentially, right? And so when you treat HIV and you get the patient's disease under control, their immune system becomes hyperactive, right? And so this patient has had what was thought to be an infection in his spine that they've been treating for like 2 months now. On Monday, we saw the patient. They did a biopsy. It showed something that looked like he has a type of blood cancer in his spine. Within 2 days, the patient went from being able to be fine. He was just having a lot of pain, started having a weakness in his legs. Basically, this thing that's in his back, which might be an infection and might be a cancer, has grown and has collapsed his back. And we need to figure out very, very quickly, do I treat this patient for lymphoma, for blood cancer? Or what do we do? And we have to do this very, very quickly because his spine is literally collapsing in front of our eyes. The pathologists are saying, no, this is lymphoma. But I said, no, like, I'm pretty sure, because of my immunology background, I'm pretty sure that this exact same thing can be seen in just a reactive process in a patient whose T cells are now starting to wake up because we're treating the HIV. It's really, really complicated. So what I was able to do is ask consensus, like, what do we know about this signaling in this population of cells? Sure enough, tons of literature on this, never in this particular situation, but there was this mouse basic science paper. When I saw that paper that this type of signaling is specifically important for the infection that this patient has, because again, this is not published anywhere, this doesn't exist. So you have to be able to make an informed decision. When I found that mechanistic mouse paper, I felt a lot better saying, like, giving a rationale for why this would be particularly important to figure out in this guy, because we know from the mechanistic, from the basic science literature, that not only is this like plausible clinically, but it's actually, there's scientific rationale for the big, huge clinical decision that we're making for this patient. But I could immediately pull the papers, pull the literature. I could bring the literature to my pathologist and say, hey, like, I know this has never been described in the literature, but this is what we would expect. And instead of just going and radiating this guy's spine, we were able to convince the neurosurgeons, hey, you need to take this guy to the operating room like now, not just radiate this thing, and then we're not ever going to know what it is, and just treat someone for lymphoma they may or not have had. And literally within that amount of time, like, I wasn't just sitting there like thinking maybe and speculating. I was able to actually pull literature, bring it to the pathologist, say, here's what we have. It sure gives you a lot more comfort saying, like, we're doing the right thing for this patient. We're not just doing this because it's a hypothesis of mine. We're doing it because this is what the literature says. You can do these things very, very quickly and very efficiently, and in a way that's not superficial, right? In a way that allows you to really take a deep dive and look at the literature yourself. So the primary literature is right there. Instead of getting reviews, a lot of other AI tools will give you reviews or give you like kind of what the AI thinks about the literature, which is, I don't really care about that. I want to know what the literature shows. So it's pretty powerful.